Hi, my name is Emily Young, and I am an RN to MSN FNP student. Today, I will be talking about how effective communication in the OR can prevent surgical errors and the complications that follow them. So, in the U.S., there are approximately 50 million surgeries performed each year. Unfortunately, within these surgeries, thousands of never events occur. A never event is considered an error that occurs that should not have happened if proper protocols had been followed. In the OR, these events include wrong site, wrong patient, wrong procedure, or a retained foreign body. When researching these surgical errors, I found that the most common contributing factor was a breakdown in team communication, followed by poor scheduling and staff shortages. Surgical errors have profound consequences. When defining an adverse surgical event, it is important to note that they are unintentional but also avoidable. Unfortunately, their consequences are extensive. Surgical errors not only cause damage to the body, but they can also have mental, emotional, and financial impact. The U.S. healthcare system spent $5.3 billion on surgical errors in 2023, noting that surgeons are the most sued specialty. Some complications that can develop from surgical errors for the patient include bleeding, infection, loss of limb or mobility, tissues and organ damage, and even death. So this led me to my PICOT question. What has been effective in improving OR safety, and what still needs to improve? Seeing the gaps in communication as a main contributor of errors, I asked, among operating staff, how does the implementation of formal communication tools, such as team steps and the WHO safety checklist, compared with current practice, affect the incidence of preventable surgical errors over 6 months? So expanding that PICOT question, population would pertain to the operating staff, surgeon, the surgeon's assistant, OR nurses, and scrub tech. But it would also involve the perioperative team, the perioperative nurses, and the administrative staff. The intervention would look at how excellent communication prevents surgical errors. So the two communication tools I chose were the Team Steps tools and the WHO Surgical Safety Checklist. The Team Steps tools include SBAR, handoff, IPASS, and briefings. These tools are known to promote vulnerability, team unity, and foster teamwork. The WHO Surgical Safety Checklist, or the WHO SSC, is a safe surgery. It was started because of the Safe Surgery Saves Lives program. It includes sign in, time out, and sign out, and when implemented correctly, reduces surgical errors. We're comparing it to standard protocols. And unfortunately, these tools are already implemented in many ORs, but are omitted because there are high patient volumes, time constraints, overproductivity, or staffing shortages. Our outcome, hopefully, is that when staff are properly trained with formal communication tools, surgical errors are reduced. And data showed that the WHO SSC significantly impacted reduction in these errors. In the studies, I noticed that the 6-month time span was pretty standard for training and implementing these tools. So in summarizing my search strategy, an academic electronic search was performed. The databases I used were CNOL Complete, Google Scholar, Ovid, ProQuest Central, and PubMed. The keywords I used were causes of surgical errors, surgical adverse events, surgical near misses, efficacy of WHO safety checklist, team steps communication tools, preventing surgical errors, and OR safety checklist. The filters I included were free, full text, and peer-reviewed, and the results I received were nearly 500 articles. The inclusions I had in these articles were surgical errors related to communication, errors, and time constraints. I also included reports in the reductions of surgical errors with communication tools and any articles that had legitimate statistical support. The articles I excluded were any article that was not in the hospital or in a surgery center setting, any article that lacked reported results. So some articles talked about implementing the process but then didn't follow up on whether or not it helped reduce surgical errors, or any articles that had poorly conducted research. So when conducting the research, what the data revealed was that the communication tools had a significant impact in reducing surgical errors, and that 6 months of training and implementation was appropriate. The conventional care processes put patients at risk. It was easy to see that the results before and after the communication tools were applied made significant difference. And I also found that poor communication was the main contributor of surgical errors, and that manifested in consent errors primarily. Poorly scheduled procedures was close behind the communication errors, just with an overload of patients. The data revealed that the solution was improved communication. And with the implementation of the WHO SSC, many studies revealed a significant reduction in surgical mortality rates and in surgical errors. And the team steps tools and the WHO SSC were proven to promote team communication. So the operating room is widely recognized as a fast-paced environment that requires a high level of attention to detail. Patient safety requires attentive routines and protocols in such a setting. Coordination within the care team is critical to preventing errors. In the OR, the patient's clinical team includes the surgeon, the anesthesiologist, the OR nurses, and scrub techs. However, as mentioned before, the perioperative team and the administration team also play a large part in sealing gaps in communication holes. To change the fractured processes, I would propose using the Johns Hopkins evidence-based practice model to guide the newly proposed plan. This model follows a structured 3-step PET framework which asks, what is the problem? What evidence supports the need for change? And what actions need to be taken to make the change? After assessing the communication gaps, I would propose implementing the WHO SSC and the Team Steps communication tools to solidify communication techniques. The Team Steps tools include, but are not limited to, briefing, debriefing, and SBAR. These tools promote the reevaluation of a process when an error has occurred and applying a new process to prevent it from happening again. The WHO SSC uses a simple process of sign in, time out, and sign out to ensure site accuracy, safe anesthesia, correct patient, known allergies, and the prevention of foreign bodies, thus eliminating never events. This process of training and implementing these tools would take place over a 6-month period. It would involve training intensives with the perioperative, OR, and administrative staff. To evaluate the plan after implementing the communication tools, interrupted time series analysis would be used to evaluate trends of surgical errors before and after application. Interrupted time series analysis evaluates trends in data before and after a new process. It is frequently used to evaluate health policies, public health interventions, and clinical policies. This data would be collected and evaluated from local and regional hospitals and ambulatory surgery centers. Trends would be analyzed by looking at previous cases resulting in surgical errors and complications using conventional processes, and then again after the implementation of the communication tools. Patient privacy would be prioritized by using encrypted databases, an activity log of access material, and removing the patient's information. The proposed evaluation tool, interrupted time series analysis, is also inherently protective as it analyzes groups versus individual information. To advocate for this change, I would appeal to the local and regional hospitals and ambulatory surgery centers. Key stakeholders would include the surgeons, anesthesiologists, and their clinical teams. I would also include the CEO, financial departments, private insurers, and malpractice insurers to emphasize the financial repercussions surgical errors can have. Another stakeholder would include an accreditation organization, such as the Joint Commission, to help brainstorm the best ways to execute the new processes. Lastly, but perhaps most importantly, I would involve patients who have suffered from a surgical error, their families, and any advocacy groups. My presentation would declare the urgency to address adverse surgical events by presenting their prevalence and their impact. I would show the stakeholders the effectiveness of the communication tools by presenting the data obtained by using ITSA. I would also describe the ease of using these tools, making this process universal and applicable. So in conclusion, the OR is a fast-paced, detail-oriented setting. Surgical errors have profound consequences emotionally, physically, mentally, and financially on all of the parties involved. Prevention is absolutely critical and is possible with communication tools such as Team Steps and the WHO SSC. With proper training and the implementation of these tools, communication is improved and errors are reduced, making the OR a safer environment and optimizing patient outcomes. And these are my references. Thank you so much.